Welcome to the explainer. All right, let's talk about myoclonus. You've seen it, right? That patient with a sudden shock-like jerk, and you're thinking, okay, where do I even start with this? Well, if that's you, you're in the right place. Today, we're going to build a super simple 4-step framework designed to give you, the busy resident, a really clear and confident way to approach this.
Okay, so here's our game plan. It's 4 simple steps. First, we're going to profile the movement itself. What does it actually look like? Then, we'll draw a map to figure out where in the nervous system it's coming from. After that, it's time for the hunt, to find the underlying cause. And finally, we'll climb the treatment ladder. It's a pattern you can literally take with you on your next shift.
You know the one I'm talking about. That sudden jerk that can be pretty unsettling for the patient, and let's be honest, for us too. So how do we go from just kind of staring at it to actually systematically figuring it out? Well, it all starts with a solid definition.
First things first, let's be really precise here. Myoclonus isn't just any old twitch. The 2 words you absolutely have to burn into your brain are brief and shock-like. It's that lightning-fast quality that really defines it.
Now, here's something that might surprise you. It can happen in 2 different ways. You've got positive myoclonus, which is what we all picture, right? A muscle suddenly contracts. But then there's negative myoclonus, which is the exact opposite, a sudden loss of muscle tone. And the classic example of that? Asterexis, that flapping tremor we see all the time in hepatic encephalopathy.
So there it is. That's our roadmap for this whole explainer. Profile, map, hunt, and ladder. Let's jump right in at the beginning with the profile.
Step 1 is all about being a detective. It's pure observation. Before we can even dream of figuring out the why, we have to carefully describe the what. Is it happening in just one tiny spot? Is it all over the place? Is it everywhere at once? Getting this initial description right is the foundation for everything that comes next.
And here, this is probably the most important thing to know in this whole section. Get this. In almost 3/4 of cases, myoclonus is symptomatic. That means it's not the actual problem. It's a big, flashy signpost pointing to some other underlying disorder that it's our job to find.
So you can pretty much sort myoclonus into 4 main buckets. You've got physiologic, which is totally benign. Think about hiccups or that weird jerk you get right when you're falling asleep. Then there's essential, where the myoclonus is pretty much the only problem. You have epileptic, meaning it's part of a seizure. And then there's that giant symptomatic bucket, and that's where most of our diagnostic work is going to be.
Okay, so we've profiled the movement. Now let's move to step 2, the map. Where in the heck is this signal coming from? Answering this question is a total game changer, because it helps us dramatically narrow down what could be causing this.
The origin can usually be traced to one of 4 main locations. It could be cortical, coming from the brain's cortex, and honestly, that's the most common one you're going to see. It's linked to stuff like epilepsy or CJD. But it could also be subcortical, segmental, from the spinal cord, or even peripheral, starting way out in a nerve root.
And let me give you a classic example of cortical myoclonus you absolutely have to know. Picture this. Your patient just survived a cardiac arrest. They're recovering, but now every time they try to move, they have these intense action-triggered jerks. That right there is likely Lance Adams syndrome, a direct result of that hypoxic brain injury. Okay, let's circle back to that huge number. 72% of cases are symptomatic. That brings us perfectly to step 3, the hunt. We've defined the movement, we've localized it on our map, now it's time to find the real culprit.
So where do you even start looking? Well, here are your 4 highest yield categories. Think of it like a checklist. First, look for metabolic or toxic causes. Check those kidney and liver labs. Second, do a deep dive into that med list for drug-induced causes. Third, think about neurodegenerative diseases. And finally, always keep that post-hypoxic cause in the back of your mind. And I can't say this loudly enough. Always, always, always review the medication list. So many common drugs can be the trigger here. We're talking about things we prescribe every single day, like SSRIs, TCAs, lithium, even antibiotics like penicillins. And this is exactly why that med review is so critical, because if you see myoclonus, plus signs of autonomic instability, like a fever or wild blood pressure swings, and that patient is on a serotonergic drug, you have to think serotonin syndrome. This is a 5-alarm fire, a can't-miss medical emergency.
All right, that brings us to our final step, the ladder. We've done the diagnostic heavy lifting. Now, let's talk about what we're actually going to do about it, with a stepwise approach to management.
The first, most important rung on this ladder is always to treat the underlying cause. Before you even think about reaching for another prescription, see if you can stop the offending drug or fix the metabolic problem. A lot of the time, that's all you need to do. Now, if the myoclonus is just so severe that you have to treat it directly, these are your go-to options. Your first-line agents are going to be things like valproate, clonazepam, or levetiracetam. If those don't cut it, then you can move on to second-line agents like phenobarbital or zonazamide.
And here's one little clinical pearl to keep in your back pocket. For a very specific type called palatal tremor, you know those rhythmic movements of the soft palate, it's worth knowing that for some reason it can respond really well to carbamazepine.
So let's end with a final crucial question. What do you do when the jerks just don't seem to fit the rules? What if they're inconsistent or you can distract the patient out of them? This is when you have to consider psychogenic myoclonus. And it's a powerful reminder that no matter how good a framework is, nothing, and I mean nothing, replaces a thorough history and just a keen clinical eye right there at the bedside.